Hello everyone. Today we are going to discuss about sulfonamides. So in this lecture, we'll learn about following competencies. So first we'll discuss about the chemical structure, then classifications of drugs, mechanism of action, antimicrobial spectrum, pharmacokinetics, therapeutic uses, adverse effects, and drug interactions. Introduction. So sulfonamides are the first chemotherapeutic agent used for prevention and treatment of systemic infections. So sulfonamides are the structural analog of para-aminobenzoic acid. They are the bacteriostatic agents. Since sulfonamide are synthetic derivatives, so these are labeled as antibacterial agents or synthetic antimicrobial agents rather than an antibiotic. Physical properties of sulfonamides, they available as a white powder, mildly acidic in nature. They form water soluble salt with bases. Coming to the chemical structure of sulfonamide, so all the sulfonamide are the derivatives of sulfonilamides. So we'll discuss brief history about the discovery of sulfonamides. So there is a scientist named Domag who used pontosil, a brick red dye for streptococcal infections. Later, he found that pontosil dye is broken down in the body to sulfonilamides, which are effective in meningococcal infections. So all the derivatives of sulfonilamides are grouped as a sulfonamide. So they are structurally related to para-aminobenzoic acid. So in this picture, we can appreciate left hand side. This diagram is this picture is depicted for sulfonamide, and the right hand side this is the structure of para-aminobenzoic acid, which are structurally similar. So this sulfonamide, they contain the sulfonamido group or sulfonamido ring. So this is the sulfonamido ring. This is a sulfonamido ring attached to the aniline. This is a sulfonamido ring which are attached to the aniline. This is the aniline, and it is uh, connected to the first positions or first terminal of aromatic ring, and in the fourth terminal there is a presence of para amino group. So in the fourth position there is a presence of amino group, and in the first position there is a presence of sulfonamido ring. So they should be this, both the group amino group and sulfonamido group, they are essential and they should be in the first and fourth positions. So in additional of substitutions on it, they decrease or abolish the activity. On an additions, this group is also present in other non-bacterial compounds like sulfonylureas, like glibenclamide, glycazide, tolbutamide, then benzothiazides, fluorosemide are the diuretics, then acetazolamides. So these all non-antimicrobial agents also contain the this group. Now coming to the classifications of sulfonamides, so they can be grouped as a systemic acting agents, local acting agents, and others. Under the systemic acting agents, based on the half-life of the drugs, T-half, they can be grouped as shorter acting agents, which T-half is varies from 6 to 8 hours. Then intermediate acting agents, that T-half varies from 8 to 12 hours, and long acting agents, their T-half varies from 7 days. So under the shorter acting agents, we have sulfadiazine. Under the intermediate acting agents, we have sulfamethoxazole. Under the longer acting agents, sulfadoxine and sulfamethopyrazine. Under the local acting agents, we have silver-sulfadiazine, mefenide, and sulfacetamide sodium. And other agents which are mainly can be act both as a locally as well as systemic purpose. So it includes sulfasalazine. Coming to the mechanism of action of sulfonamide, so as I have mentioned previously, para-aminobenzoic acid is a precursor of folic acid, and folic acid is essential for the growth and multiplications of bacteria. So we can see here the para-aminobenzoic acid or PABA in presence of folate synthetase enzyme, which is a rate limiting enzyme which responsible in formations of DHFA, dihydrofolic acid, and dihydrofolic acid in presence of dihydrofolate reductase enzyme, it gets converted to the tetrahydrofolic acid, and tetrahydrofolic acid it helps in formations of DNA and help in multiplications of bacteria. So this sulfonamide being structurally similar to para-aminobenzoic acid, they compete or they competitively inhibit the folate synthetase enzyme, which is a rate limiting enzyme, and they inhibit the bacterial DNA synthesis, resulted in bacteriostatic actions. So the actions of sulfonamide are specific in bacteria and they do not affect the human cells, as requirement of human cells is fulfilled by the preformed folic acid from the diet. So since there is a competitive inhibitions of enzyme folate synthetase by sulfonamide, the actions of sulfonamide is reversed by the para-aminobenzoic acid. Coming to the drug resistance. So there is a different mechanism which highlight the resistance development in microorganism. First one is increased production of para-aminobenzoic acid. So for example, the presence of pus or use of local anesthetic agents like procaine. So pus, it contains the significant amount of para-aminobenzoic acid as well as purine. So that resulted in development of resistance. Second one, it decreases the affinity of folate synthetase enzyme, which is a rate limiting enzyme for the production of folic acid. There also will be a efflux pump or efflux mechanism of the drugs by the microorganism or bacteria. So there will also be a development of alternative metabolic pathway for folate synthesis. Cross resistance. So cross resistance is very common among the same group of sulfonamides. And what do you mean by cross resistance? It is the type of resistance where organisms that develop resistance to an antimicrobial agent may also show resistance to other chemically related antimicrobial agents. So it is very common among the sulfonamide antimicrobial. Coming to the antimicrobial spectrum, so earlier, they are active against a wide range of microorganisms. At present, the spectrum of activity is narrow due to development of resistance. The organisms against which sulfonamide are still active are Streptococcus pneumonia, which is mainly responsible for pneumonia, which are gram-positive anaerobic bacteria. Haemophilus influenzae, which is mainly cause meningitis. Haemophilus ducreyi, which is mainly responsible, which is a gram-negative coccobacillary bacteria, which is mainly responsible for chancroid, which is a sexually transmitted disease. Also sensitive to toxoplasma, which is mainly cause toxoplasmosis, Plasmodium species responsible for malaria, and Vibrio cholerae, which is mainly responsible for diarrhea. Also, they are sensitive to chlamydia and actinomycetes. Coming to the pharmacokinetic profile, absorptions. So they are well absorbed orally. 70 to 100% absorption is mainly caused by the oral route. Distributions. So they are widely distributed to tissue and different body fluids, including CNS, CSF, so placenta, pleural, peritoneal, synovial, and other fluids. So they have high plasma protein binding property, which varies from different group of sulfonamides. So longer acting agents. So longer acting agents like sulfadoxine, they have a high tendency to bind to the albumin, which is a plasma protein, which resulted in increased durations of actions, that is 7 days. Whereas shorter acting agents like sulfadiazine, which is having less plasma protein binding to albumin, having a shorter T half. They do process drug, uh, drug displacement reactions with albumin. So drug displacement reactions mainly occurs between two drugs that bind to the same plasma protein site. So if one drug is binding to such site, then administration of second drug having the high affinity for the same site resulted in displacements of first drug from the binding site. So resulted in increased concentrations of this drug. So typical example or outcome for drug displacement reactions is cardiac arrest. So where there is an increased amount of bilirubin, is increased plasma concentrations of bilirubin resulted in deposition of bilirubin in the basal ganglia, resulted in cardiac arrest in neonates. Coming to the metabolism, so the biotransformations or metabolism occurs by the acetylation process in a liver, and the extent of metabolism or biotransformations varies among themselves. The individual response varies, and there are two types of acetylator: the slow acetylator and fast acetylator. However, the acetylated metabolites has no antibacterial actions, but they may cause crystalluria. Now, coming to the excretion process, they are mainly excreted by the kidney through glomerular filtrations and renal tubular secretion process. The part of excreted or secreted sulfonamide may be reabsorbed later. They and their acetylated metabolites are more soluble in alkaline pH, and therefore, if the urine is made alkaline and fluid intake is increased, the toxicity and crystalluria can be less likely to produce. Coming to therapeutic uses. So the sulfonamide currently they are less commonly used alone for a treatment of systemic infections due to development of resistance to many organisms, toxicity, and availability of better antimicrobial agents. So they are mainly act as a topical agents in the ocular infections caused by chlamydial species, that is conjunctivitis. So this sulfacetamide 10 to 30% eye drop can be effective in the treatment of conjunctivitis, and which are economical as compared to other antimicrobial like tetracyclines. But the effectiveness can be increased along with the while we use this topical agent along with systemic tetracyclines. Coming to the infected burns, silver sulfadiazine as an ointment topically For the prevention can be used for the prevention and treatment of infected or infections in the burns. Coming to the toxoplasmosis. The toxoplasmosis is a parasitic infection caused by obligate intercellular protozoa, that is the Toxoplasma gondii, and cats are the natural host. So usually this toxoplasmosis is self-limiting and treatments are rarely required. However, the individuals who are immunocompromised, such as patients with AIDS or transplants, are at high risk of developing disseminated toxoplasmosis. So, these combinations of sulfadiazine and pyrimethamine can be applicable in such patients at a dosing regimens of pyrimethamine loading dose of 2000 milligram followed by 50 to 75 milligram orally per day with sulfadiazine 1 to 1.5 gram orally every 6 hours plus folic acid 10 to 25 milligram orally each day for at least 6 weeks. So this combination therapy also can be applicable during pregnancy also. That is plasmosis in pregnancy. So in that situations, the mother should receive this therapy, combination therapy, pyrimethamine, sulfadiazine, and folic acid at first 12 to 14 weeks of pregnancy, and to the newborn or postnatally for 1 year. And the patient who are consuming this combination therapy usually complain of crystalluria. So patients should receive at least 2 liters of fluid intake daily to prevent the crystalluria. Coming to the malaria. So in malaria, mainly in chloroquine resistant Plasmodium falciparum, this combination therapy of sulfadoxine and pyrimethamine, which is this act as a fixed dose combinations. So where pyrimethamine is a dose of 25 milligram with sulfadoxime at a dose of 500 milligram weekly to be used for as a prophylaxis. So this pyrimethamine is slow acting agents, do not produce suitable actions alone for the acute attack of malaria. Thus, this pyrimethamine sulfadoxime therapy also can be combined with quinine for acute attack of chloroquine resistance Plasmodium falciparum malaria. Coming to the arthritis, rheumatoid arthritis. So this sulfasalazine, they are mainly effective for treating the rheumatoid arthritis because they decrease the inflammatory mediators. They do process the anti-inflammatory actions. So this sulfasalazine, they decrease interleukin 6, 12, and also inhibit release of tumor necrosis factor alpha and nuclear transcription factor kappa, a pro-inflammatory cytokines, which is mainly responsible for uh, rheumatoid arthritis. So this sulfasalazine can be effective also in the treatment of rheumatoid arthritis. Coming to the ulcerative colitis, so among sulfonamide, sulfasalazine, they help in preventing the relapse of ulcerative colitis. So they mainly use in inductions and maintenance of remissions in mild to moderate case of ulcerative colitis by producing the anti-inflammatory actions in bowel due to formations of 5-amino salicylic acids by bacterial flora because it is poorly absorbed to GIT and it is degraded by the bacteria flora in the colon to 5-amino salicylic acid. And this 5-amino salicylic acid inhibit the cyclooxygenase and cytokines, and thus it produces the anti-inflammatory actions in inflammatory bowel disease. So, in severe ulcerative colitis, this sulfasalazine can be also combined with glucocorticoids. Coming to adverse effects, so they are common and may be serious if the patient is hypersensitive to sulfonamides. So gastrointestinal adverse effect include nausea, vomiting, abdominal discomfort. Crystalluria, it is a recognized adverse effect of sulfonamides. They mainly cause due to the acetylated product of sulfonamides, which is less soluble in acidic urine, resulted in crystalluria. So, because of the depositions of the crystal in the kidney may resulted in hematuria, oliguria, and anuria. They can be prevented. This crystalluria can be prevented by making the urine alkaline, which increase the solubility and increasing the fluid intake. So apart from crystalluria, we have uh, hemolytic anemia in the patient of the G6PD deficiency, uh, granulocytopenia. So though they are very rare, but they occur in the long-term use of these sulfonamides. And hypothyroidism or goiter and drug fever, they mainly cause after the prolonged use of sulfonamide. Coming to hypersensitive reactions or allergic reactions. So hypersensitive reaction is very common in sulfonamide therapy. So there may be various type. It could be varies from simple to severe. So in simple hypersensitive reactions include skin rashes, urticaria, and serious type of hypersensitive reactions include exfoliative dermatitis, Steven-Johnson syndrome, and if the Steven-Johnson syndrome is not been treated earlier, so they can lead to toxic epidermal necrolysis. Apart from this, sulfonamide may cause kernicterus and hyperbilirubinemia in neonates and infants. So as we know, we already have discussed earlier, sulfonamide do process the plasma protein binding and drug displacement reactions. So neonate blood-brain barrier is not fully developed. So sulfonamide displaces the bilirubin from plasma protein binding site, which resulted in increased free bilirubin, which passes to the blood-brain barrier, cause depositions in the basal ganglia, subthalamic nucleus, resulted in toxic encephalopathy. So this is the effects of sulfonamide in the neonates and infants. Now coming to the drug interactions. So sulfonamide increase the activity of oral coagulants, sulfonylureas, and hydantoin derivatives by displacing them from their protein binding sites. So these drugs should not be combined with sulfonamides. Sulfonamide also should not be combined with NSAIDs and aspirin because sulfonamide are displaced from plasma protein site by these two drugs, aspirin and NSAIDs. So let's discuss about the summary of today's lecture. So first, we have discussed about the mechanism of actions of sulfonamide, which inhibit the bacterial folic acid synthesis by inhibiting the folate synthetase enzyme. They can be used as a topical agents in ocular infections and infected burns, and as combination therapy with pyrimethamine in malaria and toxoplasmosis. So they produce lots of adverse effect, including the crystalluria, hypersensitivity reactions like Steven-Johnson syndrome, hematuria, and oliguria. So the sulfonamide should not be combined with sulfonylureas, oral anticoagulants, and hydantoin derivatives like phenytoin because sulfonamide potentiate their actions.